I will talk about the epidural anesthesia and what we learned from our chronic pain clinic. Actually, I'm a very lucky person. I did a blind epidural, mainly in obstetrics anesthesia. I did fluoroscopy guided epidural, and even now I'm doing ultrasound guided epidural. So I'll try to cover this presentation in the following points. Why this topic? Because it's widely used procedure every day, both anesthesia and analgesia, both in adults and children, both in obstetric anesthesia and analgesia. We can combine it with general anesthesia or with the spinal anesthesia. If we are talking about the quality concept, quality means meeting the needs of expectations of our customers, which are patients and surgeons. So we have to do the right thing, right from the first time and every time. So I would like by the end, we improve our quality of epidural anesthesia. A common question is, does epidural space is a potential space or not? It is the outer layer of the spinal canal containing a lot of nerve roots, fatty tissue, arteries, venous plexus, as well as lymphatics. If we are looking to the MRI, we find this white triangle, which represents the epidural space, dura anterior to it, and ligamentum flavum in black behind it. As you see, there is area where the epidural space don't appear. Here, it is opposite to the lamina. So is it a potential space? So if we are doing our epidural opposite this space, it is not a potential space. We have a clear anteroposterior diameter. You can measure it by the MRI. It's 0.4 to 0.6 millimeters and even extending to 1 centimeter. And again, if you are doing epidural space opposite to the bones and lamina, yes, it is a potential space. So actually, we can say that the epidural space is segmented and discontinuous among patients. This might lead to failure of epidural catheter insertion, promoting coiling of the catheters, and might lead to a patchy distribution. And the concept of epidural predistension, which I highly recommend to use it, injecting about 10 milliliters in your epidural needle to open this discontinuous segmentation and facilitate your catheter insertion, with a lot of publication about predistension of the epidural space. If we are thinking how we can conduct, a lot of things we are needed. We are looking how to insert our needle safely. We are feeling from the nightmare of epidural hematoma. So we have to search about drugs like Plavix, Marivan, aspirin. We have to look for a coagulation profile. We have to look for signs of hematoma, especially in the eye. Again, we have to ask the patient about headache and backache, because he might claim that our epidural is the cause of such problem. The second thing that we have to know is what's the surgeon target and what's our local anesthetic distribution. So during cesarean section, for example, if usually you are targeting T4 level, and T4 means T1 sympathetic level. So doing proper epidural anesthesia for cesarean section, actually we are doing bilateral sympathetic blockade, and we are expecting severe hypotension. So we should be ready with our vasopressors, and sometimes we give them prophylactically, and we should be ready with our colos and wide vascular intravenous access. What is the patient needs from you? A lot of questions. They usually ask you, is it needle insertion painful? What will happen if I move? During operation, they ask, can I see my baby? Can my husband be with me? I'm going to see blood in the OR. I am going to hear bad news in the OR. And again, they ask about the immediate post-operative. Can I sleep with the catheter in my back? Can I walk? Can I urinate? Can I feed my baby? What about the acute post-operative pain? The delayed complication, they ask about back pain, headaches, paralysis, and paresthesia. So we should ask all these questions during our interview with our patients. You should go with answers before the patient is asking you, in a way he is not claiming and he feels comfortable, and some way of psychological support to the patient. How to conduct our anesthesia? Classically, we have two ways for insertion of our epidural needle. The midline approach, where our needle comes above the spinous process and goes directly strict in the midline and going into the epidural space, passing through the supraspinous ligament, intraspinous ligament, ligamentum flavum, and finally ending into the epidural space, which is full of fat blood vessels. It is triangular in shape with widest part in the midline, and from the periphery, it's a little bit narrower. And if we are looking here, we are going with our needle into the epidural space. You can see air, as I'm using air as a loss of resistance. Once we inject our dye in the epidural space, we find the classic spread, and I will show this in this. Some of the, most of the dye in the posterior epidural space, minimal amount of the dye reaching the anterior epidural space, and some of them going through the intervertebral foramen through one of the nerve roots. The second way is to do a paramedian approach. And during the paramedian approach, we go from laterally towards the midline, where the tip of the needle should reach the epidural space in the midline. The major problem for that the direction might be too anterior or might be too posterior. And at that time, you might do repeated attempts and the patients feel uncomfortable with a failure rate for doing epidural. The third, what is called the modified paramedian approach. Personally, I'm always using this technique. I go immediately lateral to the spinous process. Then I go with my needle perpendicular until I'm hitting the bone. I'm hitting here the lamina. So I can know my depth of my needle. I know the distance from the epidural space. So now I converted the blind technique into as if it is an ultrasounded technique, and I know my depth. So I put my needle here just lateral to the spinous process, go perpendicular, hitting the lamina. This is my depth. I add 1.5 centimeters above the depth and direct my needle a little bit up to move above the lamina and a little bit medial to reach the midline. This usually a great success rate with this approach. When I'm working in the chronic pain long time ago, I've got a lot of lessons. I will start anatomically. First, we pass through the intraspinous ligament, and in the literature, there is intraspinous ligament cyst. Here, a patient presented with localized midline back pain exacerbated by extension. When they did an MRI, they find L2, L3 cyst, as shown here by the black arrow. They inject a dye at L1, L2 level above. This normal facial spread, where they injected the dye opposite to the diseased area, they got the cotton ball appearance. Local anesthetic in the normal area does not relieve pain. Local anesthetics opposite to the cyst relieve the symptoms. So this is followed by injection of steroids, and this will lead total appearance of the pain which attributed to bursitis. So if you're coming back, this is very common in geriatrics and in athletes. And here, this case, we are doing a para-median approach, the modified technique. We hit the lamina, we direct our needle above the lamina and a little bit medial, then we get a lateral view. When we are injecting the dye, because I feel a loss of resistance, you find an abnormal spread. This is not an epidural spread. So I advanced my needle a little bit anterior. And as you see, with advancement of the needle, we got the loss of resistance. We inject our dye, our air, so you get air. Then we inject our dye in the epidural space. AP, you show the dye in the epidural space. Then we inject our steroids at the end. And while I am removing my needle, I re-inject some of local anesthetics opposite to the cyst, and these patients completely relieved after intervention. So this cyst might give us a false loss of resistance during blind epidural anesthesia. More seriously, if you are doing spinal anesthesia, you might get clear fluid coming from it. And it's a very common scenario. One of your colleagues says, I get free flow, I inject my local anesthetic, it doesn't work totally. This is a bad patch. When you ask him, what about the second patient? He says, it works perfectly. So this could be probably fluid from cyst in the interspinous ligament, which is common in old age and in athletes. If we move our needle a little bit anteriorly, we will find the ligamentum flavum. And we have a serious problem with ligamentum flavum, which is midline gap. And this midline gap, it's like a lip. Ligamentum flavum, two halves fusing together in the midline, and failure of fusion will lead to this midline gap. And at that time, your needle will not feel the sensation of ligamentum flavum. You can advance it anteriorly and go with your needle inside the spinal cord. And this publication in BGA in 2005 showed a normal ligamentum flavum appearance on the left side and ligamentum flavum midline gap on the right side. And the incidence is astonishingly, for me, for the first time, it's 35%. 1 out of 3 patients, opposite to T10 and T11. It is a very high incidence. And here, this is one of our patients that I believe it was a ligamentum flavum midline gap. We are putting our needle in the midline and we are hitting the lamina as normal, go up immediately, then we get a lateral view. Now we are injecting the dye. You feel that the dye is coming from outside to inside. It's not from inside. Again, we are injecting, it's come from outside to inside. So once I advance my needle very few centimeters, you get the classic craniocaudal spread in the epidural space with vascular spread at the end of our injectate. And here a case of paraplegia in a fully awake patient during intracord injection during epidural steroid injection has been published in the Anesthesia and Analgesia. So we should consider a midline gap at any level of the spinal cord, especially at the lower thoracic region, especially if a midline approach. And for this reason, why I always prefer the modified paramedial technique rather than the midline technique. Now, if we advance our needle a little bit anteriorly, we are in the epidural space. So could part of the needle inside the epidural and part of the needle outside of the epidural space? That's what happened in such case. We got a loss of resistance, we are injecting our dye, and as you see, part of the dye inside the epidural and part of the dye outside the epidural space. Why this happens? Because the attachment of the ligamentum flavum is not straight. It's attached above on the anterior surface of the lamina and attached below to the posterior surface of the lamina. So give the oblique approach. So your needle might be a little bit part in and part out. And when you are injecting your dye or local anesthetics, part in and part out. But the clue to diagnose this, that you get a classic or near classic normal flow of local anesthetic in the needle, in the epidural needle, but with failure of the threading of the catheter. To solve this problem, you can rotate the bevel, so all the needle inside the epidural space. And I never recommend this. This is very serious and might lead to a major dural tear. And you can advance your needle. But imagine you are doing a blind epidural and advancing the needle at that time, it might lead to dural tap with serious complication. Now we are in the epidural space with an anteroposterior diameter about 0.5 millimeters, and we are injecting our dye in the epidural space. Here we are injecting 3 milliliters. The anteroposterior depth, you see, it is wide with 1 level above and 1 level below. In another patient, we are injecting 3 milliliters again, and you see a huge cranial spread with a narrow anteroposterior diameter. So there is a great difference of this cranial spread, and we have to suspect a higher cranial spread, especially during obstetrics, where there is a uterine contraction, compression on the inferior vena cava with engorgement of the veins. So for that purpose, we highly recommend using low volumes in all patients. And if you diagnose a hypertrophied ligamentum flavum, if MRI done before operation, in pregnant females, we have also used low volumes, and you have never to inject during uterine contraction for avoidance of serious complications and a very high level. The final thing, we are in the epidural space, injecting our local anesthetic in the epidural space, And this local anesthetic might compress the vessels, what's called the perivascular compression. This point is, we are aware it for all chronic pain physicians, but some anesthesiologists neglect it. If we are looking to the blood supply of the spinal cord, we have two posterior spinal arteries with good and numerous collaterals, but we have only one anterior spinal artery, which is considered an end artery. If this end artery is diseased, we can get an anterior spinal artery syndrome. It might be diseased by aging from atherosclerosis or from vasculitis. Another thing, big volume injected in the epidural space might compress it from outside. Adrenaline, if added, might cause vasospasm. Particulate steroid might block the arteries from inside. And hypotension intraoperatively might exacerbate our condition. So here in the cervical region, you see the pulsations in the cervical epidural space. This means this amount of dye is not compressing, is not causing a perivascular compression. And here is anterior spinal artery syndrome after total hip arthroplasty using epidural anesthesia alone. It is a very serious complication. Again, in a diabetic pregnant patient, and again, why it is very serious? Because patient, you have paralysis of the anterior compartment, so the patient is paralyzed, the posterior compartment is healthy, so he is suffering from pain. So you got in the post-operative period, a paralyzed patient with pain. Some particular surgeries has associated with a high risk of anterior spinal artery syndrome, like aortic surgery, esophageal surgery, thoracic, myocardial revascularization, and CABG. And here are publications showing this high incidence of anterior spinal artery syndrome in all susceptible surgery. So personally, I say that we should consider the perivascular compression. We should avoid that. And we consider it can occur at a high-risk patient undergoing a high-risk procedure using a high-risk drugs, I mean adrenaline, which I never use it in epidural drugs, and big volume if injected. So my highest recommendation is to inject smaller volumes and giving incrementals. Particulate steroids has been totally contraindicated in cervical region. We had a lot of serious quadriplegia and deaths from steroid in the cervical region, and it is a relative contraindication in the lumbar region. So in the past, in the first part, we talk about the intraspinous ligamentum cyst problems, ligamentum flavum. Then we go into the epidural space. We show the problems of injection part inside and part outside. We show the problem of the how craniocaudal and the effect of volume, as well as the perivascular compression. Let's now to talk about what about our injected drug in the epidural space. Can it leak outside the epidural space? Here, some of the dye goes outside the intervertebral foramen. And if a big amount of local anesthetics come from one nerve root, and if you put a catheter in it, you might lead to serious transient neurological deficit along that nerve. Again, here, some pelvic spread through the S1 foramen. And during this video, we are doing a caudal epidural, and we are injecting in the caudal space and a big amount coming out into the pelvis, and the amount coming out to the pelvis add to the occurrence of urination problems, and at the same time add to loss of effectiveness of the caudal epidural anesthesia. So the effective volume of local anesthetic is the total amount injected minus the amount leaked. So we are in a mess. Are we going to inject big volumes and leading to compression and perivascular compression, or smaller volumes? And so we don't know what to do, because we are in a mess, compressing the vessels or leaking outside. So failure rate and patchy distribution could never be avoided, even with best experienced person. Another problem is the presence of epidural barriers. Here is the epidural space, and it is connected with the bony part with what's called meningiovertebral ligaments. And as you see in the midline is 71% paramedian, 17% paramedian is about 40%. And the presence of such ligaments, if you know why, some people say because if you got some leakage of the nucleus pulposus material in discogenic pain, it come here and become localized, and this is some way for protection from discogenic pain. Here, we are going with the needle into the caudal epidural space, and we injected the dye. It's totally, the patient is prone. So all of the dye on the left side coming from the left side foramen. So we removed the needle a little bit out and reinserted on the right side, and we injected the dye. We find the dye in the right side, in the left side, with a clear septum in between. So patch distribution delayed the onset of local anesthetic on one side might be explained by the presence of barriers, and these barriers could occur in the lumbar region again. Here we find area is not receive a dye, and if you look to this video and look to the AP presentation of such patient, there is a missing area, no dye present here, and can lead easily to patchy distribution. In these patients, in this particular patient, we go with the needle and epidural needle, and we inject our dye, and you see not all the anterior spread in the anterior space. If you're looking into the AP view, this nerve root missing the dye, so we try to cover this nerve root by transforaminal injection of local anesthetics, and during transforaminal injection of local anesthetic, needle is a little bit anterior, so it's an intradiscal spread, but now we can cover the area does not receive dye with a dye. So here the patient was suffering from severe pain along this nerve root. Again, in this patient, this patient is receiving radiotherapy. As you see here, we try to inject, there is a resistance and dye coming posteriorly, then suddenly there is a release of the dye into the epidural space. This is adhesions between the dura due to receiving of radiotherapy. So we have to search for adhesions. We have to ask the patient history of radiotherapy or a repeated low back pain, because repeated inflammation and might lead to adhesions and development of barriers. Epidural vascular spread. We have a lot of blood vessels, valvules connecting the epidural space with the heart and brain, connected with the intra-abdominal, and can transmit intra-abdominal and intravascular pressure, and increase incidence of intravascular cannulation. It can decrease the epidural space, so leading to a greater degree of block, and at the same time increase the risk of absorption of more local anesthetic with more local anesthetic toxicity. As we see here, some of the dye at the end goes intravascular. So personally, I believe it is inevitable that part of your local anesthetic will be in intravascular, and personally, the first dose of local anesthetic in the epidural space should be lidocaine, never bupivacaine. And if in a awake patient, you should search for circumolar numbness. Here it is a caudal epidural with extensive vascular spread. Again, it is not uncommon. Here it's L4, as we injecting excessive intravascular spread. You have to look to the tip of the bevel, it's upward. So what we are going to do is just to rotate the bevel to avoid this vascular spread, to see the classic nerve root spread. Now we nerve the bevel and we see the classic nerve root spread. Now, if you go a little bit lower to L5, it's huge intravascular spread, as if you are injecting into major artery. Nothing. So could be lead to a very serious catastrophic complication. S1, we injecting inside the S1 between, and a lot of dye going into the pelvis and going up. And once we remove the tip of the needle a little bit, you get a classic S1 nerve root injection. So intravascular injection, drugs can go to the heart of the brain. It's an unavoidable, lead to less negativity of the epidural space, higher incidence of intravascular epidural catheter insertion, higher level of local anesthetic, and higher intravascular absorption of local anesthetic with local anesthetic toxicity. One point is very important. If you keep a catheter inside the patient, there is a possibility of catheter migration, and when you are giving a top-up dose, you should be cautious that the catheter migrated into a blood vessel. So epidural venous engorgement makes epidural difficult, dangerous, and patchy. Now, I would like to talk about last 3 lessons that I have learned. Are we going to use air or saline? Long time ago in 1991 and in 2000, the publications support the use of epidural saline compared to epidural air. So loss of resistance with saline is much better than air, but recent publication showed that there is no difference between saline and air concerning patch distribution. So despite that, all the studies supporting the use of saline, recent studies supporting there is no difference. Personally, from day one till now, I'm using air. But my advice to colleagues, use what you are used to do it, but use air and avoid excessive air, because some of our colleagues use 10 milliliter full syringe to get. Here it's one case of epidural, and you see a lot of air bubbles in the cervical region. And there is one publication in literature showed that air can compress a lumbar or sacral nerve root, secondary causing nerve root compression, and you see air in the CT scan. Epidural predistension, as I said in the beginning, you have a space. If you put your needle in the epidural space, then you predistend the space with a big amount of volume. This will compress the epidural blood vessel, minimizing vascular spread, easy catheter insertion, and rapid onset of your own drugs. But the problem that this might dilute your local anesthetic. So predistension, I actually believe it is good. But 2 things are important. Which fluid are you going to use and which volume? In the literature, you can use from lidocaine 2% and down to lidocaine 0%, I mean saline. And the volumes usually 2, 5, or 10 milliliters, and rare cases of 20 milliliters. Personally, I put 3 milliliters lidocaine, added to them 3 or 5 milliliters saline, and I predistend my epidural space in every case. And a lot of publications show the value of epidural predistension and its advantage in that. Finally, the onset of epidural anesthesia. A lot of us do epidural. There is a delayed onset that might reach 20 or even 30 minutes. This is absolutely expected because the nerve, we are injecting our drug in the posterior epidural space, and the action occur on the nerve roots, which are more continuous with the anterior epidural space. Here, we did an anterior epidural space through transforaminal spread, and you find the dye hugging the posterior border of the vertebrae in the anterior epidural space. This is the site of action of our local anesthetics. But when we do a classic blind epidural, we inject our drugs in the posterior epidural space. So we need time for our local anesthetics to pass from the site of injection in the posterior space to the site of action in the anterior space. So longer time of onset time should be expected from us as anesthesiologists and should be accepted and expected from surgeons again. So to conclude my presentation, epidural anesthesia is a very serious procedure and should be tailored for every patient. We cannot say that we had a very successful epidural anesthesia, except after a period of time. So we don't have post-op complications, we don't have post-op neurological complications, but unfortunately, this period of time has not been described actually in literature. So I hope by this conclusion, I covered the topic in a nice way, and thank you very much.
Prof. Maher is here. He's here, yeah. Can you open your camera, please, Prof. Maher? Please. Yeah, Prof. Maher. Till Prof. Maher comes back, that's really very fascinating lecture, Professor Muhammad Abdurraouf. And that's really fantastic. You covered all the point of the epidural technicality and the difficulties and the challenges and all aspects of the epidural from A to Z. I believe the comment I have here from our colleagues are fascinating, and all believe the lecture. It seems that you will need that presentation, to be honest with you, to in light or shed light about the epidural anesthesia and the challenge for the epidural anesthesia. I will see if there is any few questions here. Best practice in case of wet tab. Thank you. What if you get a wet tab? What would you do, bro?
It depends in a lot of circumstances, but sometimes I continue as a continuous spinal, and at the end of the surgery, I don't remove the catheter. I just tie it so nobody can inject in it. I leave the catheter 1 day, then I remove it to minimize the post-dural puncture headache, especially obstetric population. Others, I remove the catheter and reinsert it in a level, even at the same level, and I keep the epidural catheter in place because you inject in it morphine, which proved to be effective in minimizing post-dural puncture headache, and injecting bigger volumes, because when you inject a bigger volume in the catheter, you will suddenly increase the epidural pressure, you will compress the leaking foramen, so you will immediately relieve the post-dural puncture headache. So if I reinsert a catheter, I rely on epidural morphine and continuous infusion of epidural saline every now and then to increase the epidural pressure.
If you injected the local anesthetic, would you use the same concentration or you use less concentration?
No, if I put another epidural catheter, less concentration, because now it is like dural puncture epidural with a bigger hole. So you have the drug flux from the epidural space inside, and this might lead to a higher level if you are using the same dose.
Okay. There is,
can I ask a question?
Yes, please.
Okay. What about injecting a volume of 20 ml saline in the epidural space to reduce the incidence of the occurrence of the post-dural puncture headache?
For cesarean section, I always do either epidural alone or combined spinal epidural. I never use spinal alone for the severity and problems of post-dural puncture headache. So if I've got post-dural puncture headache, with the patients cannot sit with closed eyes, once you inject 20 milliliters, within less than 2 minutes, the patient say, my headache totally disappeared. So injection of 20 milliliters in the epidural space, just saline, will minimize and will treat effectively the post-dural puncture headache. And I recommend to add on it morphine because morphine has an evidence in a Cochrane study in the treatment of post-dural puncture headache.
Morphine 1 to 2 milligrams.
Yes.
In 20 ml.
Yes.
ml or?
Yes, in 20 mL in the epidural space.
Now, can I add something? We can add an abdominal binder to increase the abdominal pressure, to reduce the leak and to reduce the post-dural puncture headache.
If happened, but if you do a big volume of saline and you repeat it with morphine, probably you will not need that.
I mean, if we have removed the catheter, after removal of the catheter.
Okay.
If the catheter has been removed, the practice of adding an abdominal binder.
You manage, yes, I agree. I agree.
Another comment, Dr. Muhammad, with an assumption of this scenario, when do you decide to remove the catheter totally? I mean, by injecting the 20 ml, you're doing some compression, you're relieving temporarily the symptoms, but when do you decide, now it's over, I can remove everything and the patient
I keep the catheter as long as the patient is in hospital. It's the last thing to do before going out from the hospital 2 hours earlier before leaving the hospital. And adding morphine to it has a therapeutic effect. You can get a mechanical effect by saline and a therapeutic effect by morphine.
Okay. Muhammad.
Dr. Maher Bash.
I have bad connections now and I return it back. There is a mixing in your talk, please, between epidural for labor in obstetrics or for OR in acute or for anesthesia.
No mixing. They are totally different epidurals. I mean, yes. is they are totally different.
Let me explain. It is
Yes,
better.
please.
It is better in obstetric anesthesia to give epidural in midline for many causes. It is more safer, more easier, and more successful than lateral or modified lateral technique.
And no vessels in the midline, avascular.
Yes. So my message to junior staff, please use midline in obstetrics, because the structures, all the structures are very soft, and it is easy to go deep to reach the cord. The best is to go in midline.
Dr. Maher, I totally agree, but I'd like to add more comment. Go midline, but go slowly, putting in mind the midline ligamentum flavum gap, because it is not in our brain. So some goes with the needle very fast. No, please go very slowly, feeling the tissues and putting in your mind there's a gap could be present in the midline.
Okay.
There is a small comment here from our colleague from Dubai, the Professor Glal Baza. She's asking about blood batch. Are we still doing it?
Yes.
Personally, I never do it. And in Egypt, it's very difficult to convince a patient that one needle causes for him dural headache and the other needle in the same place is going to treat him. So personally, I never do it, even in the worst cases. But there is a place in the literature and all over the world, very high success of epidural blood patch, and even sometimes do it preventive epidural blood patch.
But not in our COVID era.
Sure, sure.
In new guidelines for post-dural puncture headache, gabapentin is the first line of treatment. And if the catheter is still in place, give narcotics. Morphia is the best, and add dexamethasone. They give a very good outcome.
Yes, yes, Professor Maher.
Because of the sake of time, very nice presentation, Professor ا.د.محمد.